Good afternoon and welcome to Getting Scientific About Patient and Employee Engagement, a complimentary webinar from healthsystemcio.com. Just some housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemcio.com, and I'll be your moderator today. We encourage you to ask questions. You can type them in at any time in the lower right-hand corner of your screen. Leave the default at all panelists. We're going to look at those and pose them later in the program, but go ahead and send them in at any time. You've got the deck URL in front of you, so you can download it. There's a shortened URL at the bottom of all slides, and I will send it out in the chat box. And we are recording today's event. There will be an archive available, usually within 2 business days, if not sooner, and you'll get an email when it's ready and a separate registration is required. Just so you see how we're going to spend our time today, we're going to go about 40 minutes. First, we're going to hear from Chad Brisendine, VP and CIO at St. Luke's University Health Network. Then we're going to have a Q&A with Chad. So without further delay, I'm going to turn it over to Chad Brisendine. Chad, thanks for joining us today.
Thank you, Anthony. And thanks for everybody taking the time today. Hope you enjoyed the presentation, and I look forward to answering some questions at the end of our session. So I'm Chad Brisendine. I'm the Vice President and CIO for St. Luke's University Health Network. Our headquarters are located in Bethlehem, Pennsylvania, about an hour north of Philly. And we have 6 hospitals, soon to be 7 hospitals in 2016. We currently have McKesson on all of our inpatient hospitals. We have Allscripts on our ambulatory. We have a health information exchange, a patient portal, which I'll talk a little bit about, our PHR strategy in a few minutes. And we're HIMSS Stage 6 health system on the hospital and on the ambulatory side. We're in the process of implementing Epic, and we're taking our hospitals live, big bang, in January of 9 of 16, so a few months around the corner. But really I have kind of 2 components of the presentation today. One is really around our patient engagement strategy and what we've been doing and some of our lessons learned there, and then our employee wellness and what we've been doing around better understanding the health and wellness of really employees and or if you want to call it populations. So I'll talk a little bit about both of those, but they're really 2 different focuses, 2 different strategies, and then I'll answer questions at the end. Sorry about that. Just moving to the next slide here. So our patient engagement strategy, I'm going to talk a little bit about what we did around our focus groups, some of our marketing, internal communication, really how we went about onboarding our patients, and we have a lot of lessons learned in that area, and then our challenges and solutions, some of our student interns that we used to really solution around some of this, how we achieved our meaningful use and getting our percentiles up. And then the second part of the focus of the discussion today, I'm going to talk about our employee wellness program and what we really did around engaging our employees in wellness, our communication, our incentives, and some of the challenges and kind of where we are in that program. So I'm having a little problem advancing the slides, so I'm going to talk, and if the slides don't catch up, hopefully they will. So really, if you look at what we first did around our patient engagement strategy, our first thing was we really wanted to ask patients some questions. And so we started this off because we really just wanted to understand what their level of understanding around PHR were and really what they thought about this. And as we asked patients and we worked with our marketing and our IT teams to really try to understand this. And as you can see in this slide, that a significant percentage of them didn't know what a PHR was. So we knew we had a significant challenge on getting people to really understand this, not just being able to implement the technology to get to the meaningful use percentage, but even helping them understand what personal health record really meant was going to be a challenge. So if you look at, we kind of broke them down by demographics. We looked at, from the concept of do they access their information, do they do it on paper, do they do it by phone, in person, or online, and then broken down by demographics as far as what percentage would use certain of their information online and how often would they do it. And as you can see, 75% of patients, when we did this focus group on the age 18 to 34, would use patient portal, PHR, personal health record 1 to 2 times per month. So still, that's very low. When you look at the meaningful use, you know, they need to be able to view, download, and transmit after discharge. You know, even for the patient population 18 to 34, we knew that would be a challenge. And because a lot of our hospitals and our ambulatory sites, there's not a significant volume in that demographic, we knew it was going to be a challenge. And then if you look at a little bit older population from 34 to 64, that they would use it after the visits to track and test results. So we felt pretty comfortable that that range would use it after an appointment. And really the same thing for the next range is 65 plus. But we felt very slighted that we thought, you know, the younger age populations would be more adept to the technology, and the older populations would probably use it less frequently. And this focus group really definitely explained that to us, that the younger group is obviously a little bit more tech savvy than the older group. So when we focused on our materials for the marketing, we really wanted to kind of streamline. So part of our focus groups we used to find out what they thought. So we really engaged our patients in helping us do this. And so we put together, I think, some very nice stuff to introduce our new services that we had. We were able to put these at our locations, and you can kind of see, it may be a little hard to see, but you can view documents from the hospital or your physician office visits, lab and results. You can download copies of your medical records, and you can send secure messages. And we had a place for them to call, a support number, et cetera, and we had basically a help desk type team set up to really manage this. And we also created a website, evantage.com, in which we were pushing all providers, both internal employees, et cetera, to this portal, as well as our patients. And this is a sample of some of the additional brochures that we had, but we focused some of it around the proxy access as well. And the proxy access, because we knew that people really, in this older population, that their other caregivers may be assisting them, whether it was their children or family members. So we really focused around this proxy sharing and made sure that other people could build accounts and get account creation around that, and try to really simplify the account creation. So we put all that in a nice brochure for them so that other people could get access, and we knew that that may help us drive our percentages up as well. And this is just another slide on some of the key features that we had, really focused on some of the meaningful use stuff for view, download, transmit, record and monitor. And then we also had some stuff around education, because we have the education components in there where they could learn and read about their specific conditions, medications that they had, very accessible within their PHR to be able to see that information in there and get more educated on their conditions. So if you look at some of the internal communication that we did, we focused with our presidents of our entities and campuses with their teams, and we sent out information from the presidents to the employees. In addition to that, we used our learning centers. We have an e-learning CBTs online for our employees. We gave them access to that. We did podcasts around the network, and so we did a lot of education and communication about what the patient portal did. In addition, part of our internal communication team, we had folks from registration and clinical teams and executives that really helped us focus on our patient engagement strategy and what were the challenges and how we were going to really address that. So we've had and we continue to have a focus from this across multiple disciplines to really focus on our communication and what I would say working through some of the challenges associated with this. So if you look at our onboarding process, really we needed to do a number of things. We needed to validate a patient's identity, so finding out, making sure that we've got the right person. So that when we went to build their account, we would validate that they were going to be the right person to get the information. The second thing that we focused on was the collection of emails. And originally what we tried to do around the collection of emails was we were going to collect the emails and then send them out a registration after we validated them. But as we went through our onboarding process, you can kind of see that then the patient would receive inpatient care or outpatient care. Then they would be discharged, and then we would basically run a daily discharge report, look at all the patients that were discharged. We would do an integrity check of the data to make sure that the right patients were discharged and that we had email addresses, et cetera, associated with these, and then we would send them out an IPHR invite to them individually. So as patients got discharged or as they were done with their visit, they would get an IPHR invitation, and that was kind of our first round of our process. And if you look at some of the challenges and some of the solutions that we really had a challenge with the email collection, and our percentages on email collection, and I don't know how folks are doing this in other organizations, but asking patients for email, people, I guess, are highly sensitive to, spam and other stuff that they're going to get. So we did a lot around our scripting of our messages associated with this, and so we changed how we scripted messages within the organization, and so that helped with the email collection, but that didn't solve all the issues. And then if you look at our PHR invite, well, when we would just send out the information, we would get a very, very low hit rate. So then we focused on an outreach program where we had our teams calling the patients saying, hey, why haven't you accessed your PHR? Why haven't you looked at your information? What are the issues or challenges? Would you access it and look at it? Are you getting it in a different method, et cetera? So we had a whole list of questions that kind of really try to drill in to find out why people were getting these invites and not doing them. And then, so the main thing is we knew we had a low meaningful use percentage and we needed to get that up. And so we said, and we really need to put a much more diligent focus on this from a staffing perspective, not only when they leave the hospital or the physician office staff, but while they're in there. So we went and we spent a lot of time on this with our clinical teams, and we went and hired some student interns. And basically what we did was we took those student interns and we had them round on the floors and on the units, educating, getting patients signed in, and showing them what IPHR and the patient engagement solution looked like, and getting them more engaged in their stay and educating them more so that when they would go home and they would get their meaningful use information, and they would click on it and be able to see their discharge information, their visit summary, their results, et cetera, and helping do that more one-on-one with the patients. So as you can see, some of our student intern workflow that we created that really helped us. This is probably the thing that helped us the most, I would say, get our patients more engaged. So we would round on the inpatient units. We would basically send and accept an invite with them in the room and talk to them about it. We would, help them set up the accounts, show them how to view the medical records while we were in there. And still, we would continue to do our discharge reports and send all that out afterwards. And we had a much higher percentage rate once we really implemented these student interns. So as you can see, this is a breakdown of all of our view, downloaded, transfer percents for meaningful use, our target of 5%, how we were doing, based on the month, and then how our percentages are. And this is obviously last year's data, and we've continued this program. We've actually moved from student interns to full-time employees now, working on our patient engagement, just because we have a much higher success rate with this. And you can see broken down by our campuses, who has what percentage levels and how well we're doing. And again, this continues to be an upward momentum, but our program, you can kind of see where it started off and kind of where it ended up in that meaningful use reporting period. We were doing much better as we implemented some of these changes. So I'm going to stop there for a second and then kind of transition, but just a couple of notes I would say. Our main, my main takeaways at least were, we had the technology, everything was working well, and so what did we really change? Well, I think we put a more personal touch on it related to the patient engagement. We know our average age of patients in the hospital is about 65. They're not that tech savvy. They need focus and attention, and they need support. And so really by being able to provide that hands-on support and education, we've seen our numbers increase substantially associated with them being able to access the technology and the information. And we continue to make progress on that, but we know that our long-term strategy is to have people dedicated to engaging and staying connected and educating and communicating and even releasing new information. And since then, we've got the ability to do patient identity verification online as well, so patients don't need to physically be present. That was one of our challenges before, and we worked through that, where patients can now be validated with their identity online when accessing their records. So that's helped us as well. So moving to our employee wellness program. So one of the things that we really wanted to do related to employee wellness is we knew that, moving forward in healthcare, we've got to move from this, volume-based world to value-based world. And to be able to do that, we knew that we needed to focus on the employees, and that was a really good test program for us to know how are we going to really get people engaged in their care, because it's not, we're not just going to be able to collect a bunch of information and say, hey, get better. We knew we were going to have to create a culture of employee wellness. And so we created this program. It was a broad group of folks called Caring Starts With You. And basically we engaged our employees in this and focused on a whole wellness program for them. And so we leveraged our PHR to be able to do this. We also leveraged our health information exchange and technology to be able to accomplish this. But basically, we built kind of an easy three-step program for them. And so we wanted to be able to collect blood work and information so that we could really understand some of their conditions that they had. We wanted to be able to measure their blood pressure and BMI so we could really understand, basically whether, whether they managing their weight, whether they're managing their blood pressure, and what other kind of conditions may they have. And then we also asked them to fill out more of a online health assessment, which had a number of questions like, how many pieces of fruit do you eat every day, and, do you exercise a certain period of time per day, et cetera. So we knew the combination of being able to get these three pieces of information, we were going to be able to really risk stratify and understand what kind of conditions and what the risk level associated with these employees were. So some of this information that we have on this slide right here is about our communication and what we really did. And so we used our eVantage patient portal. Folks could log into this. They would go through basically putting in some of their employee information. We had this integrated with some of our employee databases to be able to really link them up so we could track them. And basically what we did is we asked them to fill out the questionnaire online and go to the lab, and then they would get a personal health, and they would also go to our machines that we had set up in the lab locations, and they would be able to get a personal health report, and it would tell them about how well they're doing, what their risk level was, whether it was low, high, medium, and what they really needed to do as far as next steps for preventive care. And so we asked them that, if they had high-level risks, that they should definitely work with their doctor. And in addition to that, we had health coaches available in this communication that they could call and ask questions to. And basically, we made sure that they understood that this information was not, Big Brother being able to look at it. It was for their own employee information that they had, and that their physician and health coaches could help them, but it wasn't for, management within the organization, because there's a lot of sensitivity around some of this, so there's a lot of focus around the communication aspect of making sure that this is PHI and it's their information and not St. Luke's as the employer's information. So we put an incentive around this to get people to join up, and we did a lot of research on this to see what kind of programs worked, and we saw very, very low levels of engagement by other programs. We decided to basically put in an increase in the annual deductible. If you continued to basically participate and just provide your information and share your information, not necessarily make improvement steps, but just comply with the program and begin to understand your health, then you kept a lower deductible, so $200 and $400 for family, and then the co-insurance, and then the office visits would stay low, and then we continue to have no charge on the hospital side. So really incentivize employees to focus on providing their information, and by being able to do that and better understand their health, they would have a lower deductible. So some of our challenges we had we leveraged our same support staff that we had for our employee engagement plan, and we had a tremendous number of calls that came in associated with this, from access to knowing some of the things where, you know, the blood pressure machine doesn't work properly and it takes the wrong number. Some people go in there like that day and maybe just have a high blood pressure day, or maybe they were stressed out or whatever. Maybe the weight scale that we had wasn't calculating things properly. We had some challenges with that. Linking the data, giving them the reports. So we had a number of challenges that we worked through that we were able to clean up related to our kiosk, et cetera. But we still had a very high percentage of eligible, and this was not just for the employees, but it was the spouses, so it was anybody that had insurance. And we had 94% of our employees and spouses go through this program and provide their results and their information. So very, very successful. We know that some organizations only had 60 to 70% within theirs, and so we felt very good about this. And kind of where we are in this program today is we are on our second round of this. Our health coaches have been assisting our employees with the high-risk areas as far as, you know, blood pressure, any kind of disease management with diabetes, et cetera. And we should be able to see how well the general population is doing over the next year to two. We're in our second year of this. We have a lot of metrics, global metrics that can say, you know, how many people smoke, what's the percentage of smokers, what's the percentage of patients with high blood pressure, cholesterol, you know, how many people are exercising and eating healthy, et cetera. So we have a lot of what I'd say global demographics on this employee population now, and we can better understand like how they're doing. In addition to this, and it's not on here, is by campus with the hospital president, and I've been assisting with some of this. We've created an employee wellness and engagement team by campus. We've been looking at everything that we can do. For example, one of our campuses, we have actually an organic farm that we've set up, and I think it's one of the first ones in the country, and basically now all of our fruits and vegetables in our cafeterias are supplied through that organic farm. And one of our, and then in all campuses, we basically decreased the costs of healthier foods. So for a salad, for fruits, et cetera, we've lowered the cost and taken a hit on that within our own cafeterias so that we can provide lower cost, healthier foods for our employees. In addition to this, we have a gym pretty much almost at every single campus associated with our employees, and we've made it as part of the employee wellness, we give them a certain number of months for free, as well as if they go so many times per year, we'll basically give them their entire amount for the gym membership back. So we've really done a lot of things, I would say, internally with our employee population, not just from being able to collect the information, but trying to create a culture of this across the organization. And while we're early on, we've already had many stories of our employees who have lost weight, have gotten more healthy, and our biggest thing will be able to see if we can make that stick and keep that long lasting. And so we've been fortunate enough to put this focus on this to see, you know, if we can change and sustain the employee wellness within our own employees, we know we'll be able to really make an improvement in this whole, you know, value-based world of making people manage conditions. And really it's kind of two components, because you've got, you know, we kind of demographic the employees into three populations. You've got the folks that are healthy and well, you've got the folks that are maybe healthy, maybe well, but they're trending towards being unhealthy, and then you've got the really chronic population that needs to be managed. And some of this stuff is, you know, exercising and food and all that stuff, and some of it's just managing chronic conditions. And so it's a combination of things to be able to do that. You know, we've got nutrition services, we've got health coaches, we've really got a team-based approach to be able to provide employee services across the gamut for whatever they need. And then the second year that we're doing this, we've really started to engage our provider community in this and expand it out broader than our own employees. And I'm sorry, our own internal health coaching team and thing. So with that, I'll open up for questions.
All right, great presentation, Chad. I want to thank you very much for putting that together for us. We've already gotten a number of questions in, and we'll get to those. I just want to remind everyone to go ahead and write your questions into the Q&A box. We default set to all panelists, and we will take a look at those. So Chad, let's get started. How many student interns did you use, and how did you determine how to split them up across your locations? We're doing something similar across our inpatient and outpatient locations.
Yeah, so, and I'll try to remember the numbers on this, but we came up with a number of patients that were going to be discharged per day. I think, and then we kind of come up with how much time that we want to spend on them per campus. And so what we ended up noticing is one of our campuses really could take a full-time person, and then our other campuses we could really share. And I think we started out with 4 or 8 part-times, and I think we're down to 2 full-times now just for the patient engagement side of that. So we had a whole bunch of interns, but it turned out to probably be somewhere about 80 to 120 hours worth of work effort to be able to handle all those discharges. So the interns we were trying to be flexible with their time, but the full-time dedicated FTEs, now we have them around, and so I hope that answers the question.
Okay.
But we said if we're going to spend 15 minutes per patient per discharge, and then how many ever discharges we had per day.
Very good. What is the method you're using for patient identity online to allow them to self-register?
Yeah, I'm trying to remember the name of the company that it has. I will ping out my team and share that back with you guys as far as the name of the specific company that we're using for that. I can't remember.
Sure, I'll get that out offline.
Okay, great. I'll get that to you, Anthony.
Vendors. Okay, thanks. I'll transmit that information. Regarding help desk, how many calls do you get per month? Is it in-house or outsourced?
We in-source it, and we have 6 FTEs on there. They do a combination of things. They manage the employee engagement wellness, as well as our IPHR, and we probably get somewhere around 1,000 per month for the patient and employees combined. And the name of the company is Fusion for the identity component.
Okay. Okay, no problem. Do you offer any patient incentives to onboard and another set of incentives to fully utilize the IPHR? No, we did some like giving away of stuff for more of a global thing, but we don't give them individual incentives. So, you know, we like gave a TV away and that kind of stuff, but we didn't, that was in our original campaigns, but we didn't give them individual incentives. Okay, very good. Is it hard to get patients together who are willing to engage in focus groups, and how did you go about that?
Well, I wouldn't say that I'm the expert at this, but our marketing team is. And so when we've needed to get patients engaged, they basically pull patients that are willing to come together, and then we set them down. So they have a method to do this. I think they use an external company for this. And so we really just work with our marketing team, and they're able to pull patients in and us ask them questions.
It sounds like it's become more and more important for CIOs and IT executives to be effective, maybe not at marketing, but at working with the marketing department, and that may not be a skill that you've learned as you've come up through the IT ranks. So talk to me about the dynamics that your department and that you have, particularly with marketing, and how you learned how to navigate those waters and make the most of them.
I don't know. I just think that I kind of look at marketing as just another physician or anyone else. They just need, you know, there's in any relationship there's a bidirectional component of there, and the marketing team needs us in IT, and so I think it's being able to deliver for them, and then inverse, we need them. We've created a strong partnership, but what we really did is we set up a team from the beginning, and we asked marketing, could they have someone participate with us on this and assist us with this? And they participated with us, and I think by getting on early and understanding what we were trying to do, it became natural. And the other thing is marketing doesn't have a lot of money to do this, so we made sure that we had money in our budget for marketing. And I think by having the money as well as engaging them early, they were more than glad to participate with us.
That's the key, right? I'm not asking you for any money. We've got the money. Just help us out.
Yep. And that was the thing. It was like, okay, well, you've got this, we'll help you get this stuff printed, or we'll do this design for you and all kinds of stuff. So at least when I've had conversations, the marketing budget's always limited, and that's, I think, where the challenge comes into play.
Interesting. Do you think health systems sometimes focus so much on patient wellness that they forget the employee wellness component, which you discussed?
You know, I would say that yes, and the only reason why we went after the employees is because we felt like it'd be a lot easier to have more conversations with them. But by doing this, we're thinking, well, why wouldn't we be doing this all the time, right? We're in healthcare. We should be doing this for our own employees and be healthy. So I'd say in general, yes. But what really interested me and what kind of came to my light was how many resources we really have available to help our employees do this that we're not leveraging. So it's a tremendous opportunity of things that you probably have in your health system that your employees could get access to that really doesn't cost you a lot of money or anything. So that's probably the thing that came to my attention. We haven't spent a tremendous amount of money on this. We've done all of it mainly internal, and we've been able to, you know, provide a lot better service for our employees. So it's been good.
Can you talk? Because one of the biggest challenges that health systems have as we go forward and things change is you're more and more on the hook, so to speak, for the health of your population, and a lot of that has to do with incentivizing healthy behaviors, and you talked a little bit about that. But it's got to be more than just, don't you want to be healthy, right? I mean, there has to be different financial components and other components. Is that necessary? Is that what it takes to get change? You can't just rely on the, you know, be healthy mantras, right?
I don't think you can. I think you've got to do, I mean, at least our strategy has been, we've got to do everything. We've got to do, you know, one strategy won't fit all. Some people want to be healthy, they just need some extra support. Some people will need to feel the financial. I mean, you start feeling 1,000, 2,000, 3,000, 4,000, maybe that's going to get you moving in the right direction. The other thing, maybe just they don't understand, they don't have enough education on their conditions, et cetera. So I think it's a combination of, you know, A, motivation for some people, and B, maybe resources associated to a system. And so we've tried to do both.
Mm-hmm. Is the educational material available to the patient specific to their illness and condition, or is it searchable on all topics?
It's searchable on topics, but it puts a link in there to their condition and next to it within the PHR.
Okay. Did your findings from the focus group conflict with any of the things you had to do under meaningful use? So, for example, did you find, were you in that position that, you know, people have said they found themselves in under meaningful use, which is, we have to do this, but we don't really want to do this, or we think this is kind of a checkbox that, you know, we would never have created this checkbox. So talk about how meaningful use meshed with your findings from the focus group.
Oh, man, we had a lot of conversations on that. And we had calls with PwC and the advisory board and pretty much everybody that would be willing to talk to us about you know, how to manage this, because part of the challenges that we had is like, okay, are we just trying to get the checkbox, or are we actually trying to get people to use it? And I'll just be honest, I feel like we're getting our employees to use it more than we are patients, because we've got what I would say bi-directional work inside of there. And so I think today the meaningful use stuff is, and this is my opinion, this isn't anyone else's, it's basically getting awareness done and getting more people engaged, but it hasn't created this where I'm engaged in my care yet. So I think it's a good step in the right direction. And while some of the criteria and the way that the discharge information and how it had to be processed, I think has a lot of improvement, I would say it met its original goal, which is to just get people more engaged, get them more educated. Because if you look at some of our stats, you can see that people didn't even know what this stuff was. So if we got that accomplished by just getting our patients more engaged, that there's information available online, they can get access to their records, it is their record, it's available to them, I think we accomplished that. So I kind of look at it from that angle, and a little bit more of an optimistic first step approach. Some of the technical stuff needs to be a lot simpler is what I'd say. It's too detailed, or and it's not processed properly. I mean, e.g., we had to put people in place to kind of push to a number versus, you know what I mean, try to slow this thing in, if that makes sense. So,
right.
But I think actually, you know, because we had to put people on this and put them in their face to get to the numbers, I actually think that was a positive thing, because basically it meant that we really needed to spend more time on discussing these things with our patients, and we probably weren't doing a good job of that. And so this kind of helped us push that momentum and do more communication to the patient.
And that at the elbow support for these account creation and first time going into the portal, that's absolutely necessary?
I mean, I think that we wouldn't have got our numbers if we wouldn't have done it. We weren't getting our numbers if we weren't holding their hand. So we know through our work that holding their hand and working with them through it got us there. Without it, it wasn't. Now, maybe other people were more successful with that, but at least in our timing, and as everyone knows, when you're trying to hit the meaningful use, you don't have a lot of time to sit there and kind of wait for things to flush out for a year or two.
Right.
You've got to kind of try some things, and then if they don't work, adjust. And so we were adjusting quickly enough to kind of get to our numbers. If we would have not done that, would we have taken a longer time and a softer approach? Maybe so, probably. But we really didn't. We had to put resources behind it to get to our numbers. So, I mean, that's kind of where my head's at on it.
Right. And the question is, you know, when you have to do that to make your numbers, so to speak, does it stick? So those at the elbow kind of log in together things, are those people coming back? Well,
I think that we definitely see people coming back in the outpatient world, a lot more in the hospital inpatient side. I mean, the hospital inpatient side, I mean, hopefully you're not there enough to want to go back, you know. And so I don't think that those events happen enough. But on the outpatient world, you know, you're seeing your doctor, depending on your age and your condition, you're seeing them a lot more regularly, so you're going to be more engaged. So I think it's, you know, your health status and where you are and how many times you visit. So I think, honestly, I think personally, probably the hospital shouldn't have had this, and it should have been for the outpatients.
Right, right.
But we had to focus on it. I mean, you come in for a one-time trauma event, you know, how long, and you're 25-year-old, are you going to really be engaged in your PHR?
No, that's a good point.
Some of that stuff.
Yeah. I think I have one more question for you, unless we get another one in while you're answering. For people that are facing the same challenges but are in a different type of organization where they don't have access to student interns, any idea how they might provide for that at the elbow support?
Well, I think that, you know, it has to be an ROI thing. Are you going to chase the money and get the penalties associated with meaningful use? Do you think it's the right benefit, and how much money you're going to put behind it? I would probably say that the only other option we really had was to really train and educate. If you're going to do this on no money, really train and educate our staff to do this at discharge and have someone accountable in the hospital. Again, if we would have taken that over a longer period of time and we wouldn't have been rushed by the meaningful use, we could have gotten that done. But we were sitting there trying to say, okay, we've got, you know, 2,000 people that we need to train and educate on how to do this and do it effectively and get them educated, and they're already really busy, and how well will they do it, and how long is that going to take us versus putting a dedicated focus on this. So I would say if you're looking at it on a short-term basis, you're going to have to put dedicated resources from some avenue. If you're going to take a slower approach, I think, you know, train and educate the staff that do discharge work and get them educated and get them trained and work it that way. I mean, that would have been my approach if we would have had, you know, 2 years to meet this.
Well, do you still think that the long-term approach, you know, can you do both at the same time? Meaning, okay, let's do this to meet our numbers, but we're also taking a long-term view of this, you know, even beyond meaningful use. So we do want to put in some training for the existing staff, and also maybe add someone who's or one or multiple people who are going to be in charge of this.
Right. Well, we have some of our campuses. We have not all of our campuses are leveraging these. We have some of our smaller campuses leveraging their own internal staff. So we've got a couple small campuses doing this. This is our larger campuses that have a little bit of challenge, but we do have some of them doing it. What our plan is to do is we're rolling out Epic's basically patient bedside MyChart system. We plan to leverage that while they're in the stay. So I think being able to give them technology that has multiple functions, not just one, right? So how many patients are going to be sitting there looking at their health information is all they can get is their discharge information, and that's not going to happen until after their hospital stay. And they already know all their discharge information because they were sitting in the hospital for a week, right?
Right.
So
right.
I think part of this is that really that information should be, while that patient's in their stay, they should be engaged in it, looking at it, reviewing it, et cetera, not after discharge. So I just think it's that step of where the technology needs to be that would bring it in the right direction, if that makes sense. We want them to be engaged in their health, not after discharge or whatever, all the time, right?
Right, right.
So I actually think it should have been, did they log in and look at their medications and labs and stuff like that while they were in the hospital?
That's a good point.
So that's why we're looking at focusing more on more of a global strategy around patient engagement, patient satisfaction while they're in the hospital. I'm obviously using one of Epic's new tools to do that.
Very good. Well, that's about all the time we had for today. I want to thank Chad Brisendine for joining us. As I mentioned, you'll get an email when our archive is ready, usually within 2 business days, if not sooner, and a separate registration is required. For those of you with the CHIME CHCIO certification, attending our webinars gets you 1 CEU for each event, so let CHIME know you were here, and if you've asked us to do that, we certainly will. Sponsorship opportunities, contact Nancy Wilcox. General questions and comments, you can reach out to me, and you can go to our site to see our upcoming slate of webinars and our last 12 months of archived events. So with that, I again want to thank Chad, I want to thank our audience, and everybody have a wonderful day.
Thanks, everyone. Thanks, Anthony.